Next speaker is luckily to have is my junior in Warangal, and is so as a senior I'm proud of as a chairperson. Kiran Peddi. We used to call Kiran, but everybody knows by name Peddi. So he's a gastroenterologist trained in UK, and he's a MRCP examiner. Very few people in India as a MRCP examiner, international examiner, and he's a specialty gastro trained in UK. Because of love for India, Bharat, he came from UK to serve the Indian patients. That's why my father and my uncle and all family members are his patients only. So lucky to have a speaker like Kiran in the morning time. And reputation, sky is the limit for is to talk about his papers and this thing and this thing. And his special interest in IBD who trained in Australia. And Kiran, we had one case in presently admitted in Gandhi, 16 years girl, IBD with bleeding rectum and polyuria, central DI. Okay. Central DI with IBD, bleeding per rectum, presently admitted, and we are working of this thing. So 16 years girl with IBD for your specialty interest.
Probably the GI is the closest organ or system involved in relation to diabetes, because diabetes is very closely associated with gut disorders, the luminal intestinal disorders, liver disorders, and also pancreatic disorders, as all of us know. So when it comes to the luminal pathology, diabetes can affect gut by autonomic neuropathy, small intestinal bacterial overgrowth, and also a lot of diabetes drugs can cause a lot of GI issues. We all know that liver is again affected by diabetes or associated in the form of fatty liver, non-alcoholic fatty liver disease, which can lead to chronic liver disease. Pancreas, we again know that chronic pancreatitis. One second. Chronic pancreatitis is again closely related to diabetes. And there's a lot of emphasis on a lot of research in the focus area of the role of microbiota and diabetes. We'll talk a few things on it. So coming with starting with the luminal pathology, diabetic autonomic neuropathy, which is called, in other words, enteropathy and gastrointestinal tract. We commonly see a lot of diabetic patients, almost 50% of the patients with diabetes experience disabling GI symptoms in the form of nausea, vomiting, bloating, early satiety, and also abdominal pain. You can divide these symptoms into foregut symptoms in the form of nausea, vomiting, and bloating, or mid and hindgut symptoms in the form of abdominal pain, diarrhea, constipation, and also fecal incontinence sometimes. And it's mainly related to the dysmotility, which is a result of diabetic autonomic neuropathy, which leads to enteropathy. Interestingly, esophageal disorders are the commonest, but paradoxically, the gastroparesis is the most widely studied in patients with diabetics. Sorry, the slides are taking some time to move. Okay, so this is a pictorial view of enteric nervous system, which is very complex and very meticulously organized nervous system within the gut wall. So the three common nerves, the group of neurons involved in enteric nervous system are IPAN, intrinsic autonomic neurons, and glial cells, and also interstitial cells of Castle, which are called pacemaker of the intestine. So the pictures are moved actually. So fine. So hyperglycemia and diabetes, and how it is going to affect gut autonomic neuropathy in the form of altering metabolism. We all know that hyperglycemia can initiate a trigger of alternative metabolic pathways like polyol pathways, and it can lead to advanced glycated end products. I think the slides are blurred. You can see, it is not the exact slides, but it is changed a bit on the email, I think. Fine. So advanced glycated end products, which can actually trigger free oxygen radicals and also cause oxidative stress on the neurons. And the interstitial cells of Castle, which are regarded as the pacemaker cells for intestine, the hyperglycemia will result in loss of interstitial cells of Castle, which leads to decreased contractility and then dysregulation of the movements of the intestine. And there's hyperglycemia per se will cause osmotic stress and inflammatory pathways which are triggered in many ways. Again, the slide is condensed a bit. So the upper GI manifestations are gastroesophageal reflux disease and Barrett's, which can lead to Barrett's and then adenocarcinoma later on. And lower GI manifestations are small intestine motility disorders and small bowel bacterial overgrowth. So there are various modern techniques for assessing GI motility in the form of gastric emptying scintigraphy and whole gut scintigraphy and radionuclide imaging and wireless capsule, motility capsule. But to be honest, not all of them are widely available even for the routine gastroenterologist, but gastric emptying studies are commonly done. So how do you manage diabetic enteropathy? So once enteropathy sets in, there is no obvious cure, but we can prevent or delay neuropathy by strict glycemic control. And the gastroparesis can be managed by dietary modifications, prokinetics, tricyclic antidepressants, and also various endoscopic procedures of late took priority in the form of balloon dilatation of the pyloric channels, Botox injection of the pyloric channel, and also there is a new procedure called GPOEM, gastroparoral endoscopic myotomy procedure, where we can tunnel close to the pylorus and then done by only few gastroenterologists. And the diabetic enteropathy commonly manifests as a diarrhea. So this can be managed by fiber supplementation, which increases the stool consistency, increase the holding capacity for the patient. Loperamide can also be used. Constipation can be effectively tackled by prucalopride and abdominal pain with tricyclic antidepressant and SSRI. Again, this slide is a little blur, but anybody with diabetes presenting with malabsorption features like B12 deficiency, vitamin D deficiency, and anemia, please think about celiac disease, because the diabetes hyperglycemia per se can cause immune upregulation and can cause small intestinal damage, resulting in malabsorption features. We are all very, very familiar and worried about NAFLD and diabetes. And nowadays, the NAFLD is perceived as anybody you do ultrasound, they get a fatty liver. So 25 to 30% of general population has NAFLD, and it is very strongly associated with the metabolic syndrome in the form of obesity, type 2 diabetes, and also dyslipidemia. And NAFLD is also associated with other endocrine disorders like hypothyroid, PCOD, psoriasis, and osteoporosis. It has two steps. Whenever we talk about NAFLD, we either talk about steatosis, that means just a fatty liver alone, that is called NAFL, NAFL, and if the fatty liver is associated with inflammation and fibrosis, that is called NASH. And it also have previously we used to think that anybody with diabetes has a risk of developing NAFL, but nowadays the latest research is showing that it's actually a bidirectional relationship. And that means anybody with NAFL can also be at a higher risk of diabetes. So type 2 diabetes and NAFL and triglyceride-derived toxic metabolites accumulate in the liver, pancreas and muscle, leading to lipotoxicity, which can increase hepatic insulin resistance, thereby predisposing patients with NAFL to type 2 diabetes. So 2 to 5-fold increase in the risk of type 2 diabetes in NAFLD patient. These are a few of the studies showing increased incidence of type 2 diabetes in NAFLD. I won't go into details of this, but you can see it's actually spelled other way around. So the last column on the left, if you can see that, it's cases with type 2 diabetes versus NAFLD versus non-NAFLD. So 8.1 versus 1.8, for example. So people with type 2 diabetes, people with NAFLD has got increased incidence of type 2 diabetes. And what about mechanism of NAFLD in diabetes, reverse way? So insulin resistance and then a lot of gene polymorphisms, hyperglycemia, hyperinsulinemia can increase free fatty acids and lipid deposition, leading to NAFLD and NASH and thereby hepatic fibrosis. This again some of the studies showing increased incidence of NAFLD in type 2. So what I showed in the last 4 slides is increased incidence of type 2 in NAFLD and increased incidence of NAFLD in type 2 as well. So that's a bidirectional pathology. So that brings out the importance of screening of all our patients. And most of the European guidelines recommend screening all the patients with NAFLD for diabetes. Whenever we get patients with NAFLD, we should be screening for diabetes in the form of random glucose at least and HbA1c. And American Diabetes Association recommends screening all diabetic patients with elevated liver enzymes and or liver stiffness for NAFLD. But American Association of Liver Disease doesn't recommend the same way. So essentially, we can adapt to our practice, but my recommendation would be all of us gastroenterologists should screen for diabetes, anybody is NAFLD, and all diabetic patients should be screened for NAFLD as well. And this is a big area nowadays, gut microbiome and diabetes. When I say gut microbiota, which implies that there are 10 to the power of 14 bacteria in the GI tract, and the term microbiome refers to genome of all these bacteria. There's a subtle difference in the terminology. And whenever we get altered composition of intestinal microbiome, and it can contribute to obesity, diabetes, and heart failure. And a lot of research is going on in this area now. So commonly there are 6 phyla of microbiota in our intestines, and the common phyla are firmicutes, bacteroids, protobacteria, actinobacteria, fusobacteria, and vericomicrobia. So any disturbance in this composition of these 6 phyla, we call it dysbiosis. The dysbiosis will predispose the patients for diabetes. Um, so these are various ways. You can go for the microbiota increasing production of short chain fatty acids, and these are various mechanisms how the dysbiosis can predispose to diabetes and all. So unfortunately the slides are a little slurry here. So the dysbiosis can lead to decrease in short chain fatty acids and loss of self-tolerance and increased upregulation of immune systems and alteration of TUR4, and then thereby leading to development of type 1 diabetes. Similarly, role of microbiota in type 2 diabetes, increase inflammatory pathways, insulin resistance, and then development of type 2 diabetes. So it's clearly a lot of studies are showing that any disturbance in the microbiota in the form of dysbiosis predispose the patient to type 2 diabetes. So again, the therapeutic implication of this is if you have therapies which can correct this dysbiosis, that can improve glycemic control in our patients. So there are other GI diseases which are associated with diabetes in the form of autoimmune gastritis and pernicious anemia. Colorectal cancers are also increasing incidence in patients with diabetes, and pancreatic exocrine insufficiency is also associated with diabetes. So ladies and gentlemen, in summary, gut diseases contribute to a significant proportion of complications among diabetic patients. We need to be aware of various manifestations of enteropathy among diabetic patients. So as soon as they complain of early satiety, upper GI symptoms, and abdominal bloating, we need to focus on glycemic control and target strict glycemic control for improvement of enteropathy, because there is no obvious cure, but by controlling the glucose levels and improving the glycemic control, one can prevent the progression of enteropathy. And we need to consider screening all our diabetic patients for NAFLD and also vice versa. And anybody diabetic patient presenting with malabsorption, we should suspect celiac disease. And we also need to be aware of other rare complications of GI complications of diabetes, like colorectal cancers and celiac disease, pernicious anemia, and autoimmune gastritis. Microbiota is an exciting area in diabetics, and one can consider pre and probiotic, or in other words, symbiotic combination. Symbiotic is a combination of pre and probiotic. Symbiotic supplementation as an additional supplement for better glycemic control, in addition to the standard diabetes therapy. Thank you very much.
So thank you, Kiran, for sticking to time, and he has got a FRCP London for a medical contribution to medical education. I think he has given for the degree for this talk, short and sweet talk, right? And any questions? Any questions?
Yeah, I have one question. The usual practice in our clinics, all of our patients have some GI, upset. How much of that is due to metformin as opposed to irritable bowel? Nowadays, we hear irritable bowel quite frequently. What should we as diabetologists do to handle GI symptoms in our clinic?
Actually, I had a slide on metformin and GI, but I deleted for some purpose. The very pertinent question, Dr. Sham. So, a lot of patients complain of GI intolerance with metformin. So, my algorithm is I exclude other possibilities and treat blindly. If the patient is not willing for going for any evaluation, I treat for small intestinal bacterial overgrowth and still not getting better, and all the investigations are normal, endoscopy, colonoscopy normal. I recommend to my diabetologist for changing the metformin. I'm anti-metformin person. And wherever I go, my gastroenterologist, my colleague diabetologist always say that you don't like metformin at all. So, a very pertinent question. You need to evaluate other causes first and treat for small intestinal bacterial growth if still pertinent. And enteropathy we can't prove, but at least metformin we can stop and then look for the benefit.
We had a lot of experience of diarrhea, metformin causing diarrhea also. So once you stop it, automatically diarrhea is going to stop.
Yeah.
So see that this thing, reduce the doses and see that again, if you want to start again, start with low doses and try to slowly try to upgrade. And Kiran, there is any difference between before giving a food and after giving food? Any GI side effects with metformin? Any studies are there?
Metformin?
Metformin before giving, after giving food?
I'm not aware of any studies looking at that, and also I'm not aware of any smaller dose of metformin is better tolerated in terms of GI point of view, but a lot of patients come back with a better tolerance, but I tend to change it altogether. But I'm not aware with relation to the food any studies putting benefit or more harm.
So that problem is very, very important actually to be addressed. So metformin, as surprisingly, many of the patients who have been on metformin for a longer period of time, many years, and they tolerate it very well, but subsequently
Correct.
they develop a problem, and some, as you said, like some patients do respond to the stopping of metformin, but again, after a gap of at least 6 months or 1 year or so, again, reintroduction with a smaller dose again, maybe a better option, because that's one of the important anti-diabetic medication which we have in our hand. So addressing the insulin resistance, which is an important pathophysiological mechanism in type 2 diabetes patients. So that's what we do in our practice. Majority of the time, sometimes they do respond with the stopping, but again reintroduction makes them little tolerable to the metformin. That's what we have observed in our practice.
Yes, ma'am. Very true.
Thank you.
Any questions, please?
For a longer time, is it good? Or you are saying that you are anti-metformin, but in US actually, in US, so many people they are giving only metformin for a longer time with higher doses. So that has been happened in our family itself. So what is your comment on that?
It's okay. Any prokinetic is okay, but long-term basis they lead to a lot of side effects, including QT prolongation and a lot of other side effects as well. And the newer prokinetic, which is procalopridone, is supposed to be slightly better, and cinetapride is also supposed to be slightly better. So once you use short-term, then if you prove that it's only gastroparesis, nothing else, one can resort to other therapies like endoscopic therapies like balloon dilatation of the pylorus and also G-POEM sometimes. But we have to prove that there is no other pathology.
Thank you, sir. So, congratulations for the excellent talk, Dr. Kiran. I just wanted to supplement what Dr. Uma was saying, that metformin may be given in spite of GI symptoms when it could be because of many other factors other than metformin intolerance itself. So, how would you sort of practically differentiate these? Because it could be because of autonomic neuropathy, it could be because of bacterial overgrowth, it could be, several factors could be causing the GI symptoms in people who are on metformin. So where would you actually stop metformin, and how would you sort of differentiate these features? If you could just highlight that, that will be good.
Yeah, we're just talking on that, Dr. Rakesai. So basically, we need to exclude other pathologies, including small bowel bacterial growth, by doing iodine breath test. The only two conditions we cannot differentiate, cannot prove is metformin-induced enteropathy or is it autonomic-induced enteropathy. We cannot differentiate. We just have to change the medication and see if it improves, that's the culprit. If not, probably enteropathy, patient has got enteropathy, not getting better. Even if we stop metformin, one can continue that. Because there is no test to prove enteropathy unless, we do gastroparesis studies and colonic motility studies and all, but not widely available.